We can go ahead, ma'am, the session.
Good evening. I hope my screen is visible. I hope I'm audible.
Yes, ma'am.
Great. So, good evening, one and all. Today's session is on environmental surveillance. This is one of the topics that comes in the periphery of infection control, but nevertheless, it is associated with a lot of controversies and a lot of misunderstandings. And it is one of the points where even the professionals who are not
recording in progress.
Infection control also have queries and often leads to a lot of misinterpretation because once a culture or a surveillance sample is sent where it is not actually required, the interpretation itself becomes difficult. So we will go through this one by one. Before that, I will briefly discuss the concepts and then we will go into the slides. So for a brief while, there won't be change of slides much. I'll be speaking. So the first and foremost, the most important concept that we need to understand is surveillance samples or surveillance cultures are routinely indicated only in very few contexts. Surveillance samples to begin with would include air sampling, surface sampling, water sampling. These are the three important surveillance samplings that we consider. Now, in this, not all of them are routinely done. In most of the institutions over the years, what has been taken as a very serious element of surveillance sampling is surface sampling. There will be a lot of swabs which are taken from used for sampling random surfaces in an OT, in an ICU, in a transplant ICU, in a BMT unit, in wards, in labor units. There will be a lot of these swabs taken and sent to microbiology. The purpose of which is not understood and the purpose of which is not realized by either the person who is taking the sample, the person who is requesting the sample, or the person who is interpreting the sample. First and foremost, what we need to realize is surveillance sampling, especially surface surveillance, the swab stick collection, is not routinely recommended. There is no scientific evidence and there is no guidelines which say that this is of any use. In fact, CDC recommends targeted microbiological surveillance of air water surfaces, especially surfaces, for defined indications. You do surface sampling, but when it is indicated, for no reason, do not take samples and send. When you do not have a purpose for sampling, how do you interpret the result? For example, if it is in a clinical situation, if it is a person who does not have any symptom of UTI and you send a urine sample, how do you interpret the growth? Similarly, when there is no reason per se for doing a surveillance sampling and you do a surface sampling, you send a swab, how do you interpret? It is absolutely unscientific and there is no guideline which recommends that. So CDC recommends to perform targeted microbiological sampling, especially of surfaces, for defined indications when there is an outbreak investigation. This we saw as part of the last session that I took. Outbreak investigations, once you form the hypothesis, to come to a conclusion as to which of these hypotheses is actually true, we can do a sample. But in that case, we know what we are looking for. If you have an MRSA outbreak in your hand, then you know that in the surface sampling you're looking for MRSA, you're not looking for anything else. So you should have a clear you're looking for. I'm looking for MRSA because we have an MRSA outbreak. So in all the surface sampling, the swabs, you'll be looking specifically for MRSA. Otherwise, these samples, one will yield E. coli, one will yield gram-positive bacilli, one will yield spore bearers, one will yield pods, one will give MRSA. How will we interpret that? That is not possible. Second thing is research purpose, to see what are the bacteria. For example, what are the bacteria that are colonizing the doorknobs, or some such very specific, or for no specific reason you are looking at what is happening. Like that research. Monitoring environmental hazardous condition. For example, if there has been a construction or a renovation and you want to see if the disinfection has been done properly, but not on routine basis, but if it is after a construction or a renovation or a change, then you can do it. Or to evaluate change in infection control practice. For example, you used to do surface disinfection and suddenly you have decided to do surface chemical sterilization or high level disinfection. You have changed your practice and you want to see if the microbial burden has decreased. So if you have a specific purpose in your mind, sampling would make sense. If you do not have a specific indication or a purpose, then surface sampling is something that leads to a lot of loss of resources and time. It is up to infection control professionals to uphold this idea and ensure that all the stakeholders of infection control realize this, and this is in fact being followed. Don't take surface samplings and swab stick samplings just to appease people, or just to give a tick mark that this has been done in this month. Not for that. Do it only when it is indicated. Then we have air sampling. Air sampling is not indicated for every clinical space. It is required for clinical spaces where there is where you want maximum sterility or minimum microbial burden in the air. And as a routine practice in all healthcare facilities, wherever you want to achieve very low microbial burden in the air, you will automatically have installed a HEPA filter. Because without a HEPA filter or a HVAC, it is not possible to contain or control the microbial burden of air. So to see if these things are happening and the air filtration and the containment of microbial burden is going as per plan, to see if that is achieved, you do a air culture. Otherwise, in a routine ward or in an area where people are moving in and out very frequently, if you go and keep a air settled plate or a air sampling methodology, you won't be able to interpret, because that is equal to keeping a plate in an office area also. You can't say that an office area should have a sterile air or should not have much microbial burden. That is not possible. It cannot be achieved also. So you should have a clear idea of which parts of the hospital you want to have with minimum or controlled microbial burden. What has been done to achieve it? It could be HEPA, it could be laminar flow, whatever it is. So to see if that is going as per plan or as per the requirement, that is why you do a air sampling or air surveillance sampling. Again, depending on the place and depending on the part of the hospital, depending on the services provided in that unit, your frequency of sampling, your interpretation of the sample, everything would change. Now, the third one is water surveillance sampling. Water surveillance sampling is something that needs to be done on a periodic basis. This is not something that we do only when a problem arises or to look for specific things. Water surveillance sampling is to be done periodically, because the water that we use in a healthcare institution is for multiple purposes, including for different purposes ranging from consumption to sterilization, washing of clean and sterilized instruments, your dialysis machine, your RO water. There are a lot of uses in your laundry. In a healthcare facility, water is used for a lot of purposes, most of which range in the cleaning and disinfection process itself, and a lot of which are going to be used on the patient also. So it is very important that the water is of good quality and it should not contain any evidence of not being fit for use. So water surveillance needs to be done periodically. But again, The periodicity would depend on the unit, the type of service which is being provided in the unit, and the interpretation should be done by a laboratory which is certified in reporting that. See, all hospitals, most of the hospitals would have a microbiology laboratory. It would make sense to take a sample from the water source and send to the in-house microbiology laboratory, because you have a laboratory there, they are functioning every day. Their microbiologist there knows what it is being looked for. It might be very tempting to send it to the in-house microbiology laboratory and keep the report, but remember that even if your lab is NABL accredited, it will be NABL accredited for medical testing. Whereas water surveillance is not a clinical sample, it is not a patient sample. So your laboratory, which is located inside the hospital, is not likely to be accredited for water sample reporting. You can do it in-house, but at least once in 6 months, it is a good practice to send sample to accredited laboratories which have water testing as a scope of accreditation. Then it would make more sense. What you are doing on a more periodic basis, you can do it in-house. That is a suggestion. What you do with your in-house laboratory is completely up to you, but for uniformity's sake and for better acceptance of the report among even accreditation or during inspections, it is good to have once in 6 months from an accredited laboratory which has water testing in its scope. So these are some basic idea or basic concepts pertaining to environmental surveillance in a healthcare facility. Now we'll take them up one by one. We'll go through the slides and we will go into a little more depth in some of them. So routine environmental microbiological sampling is not recommended as part of quality assurance program except for the following situations where routine sampling is indicated. So in the three mentioned situations, routine sampling is indicated. First is monthly water surveillance, hemodialysis applications, spinal dialysate, etc. There you should have a monthly water surveillance. Air particle counter for regular maintenance of air handling system and biosafety cabinets. Again, this would not be your routine wards or patient care areas. This would be areas where you expect or where you want the microbial burden to be less and where you have already installed mechanisms to control the microbial burden. So for regular maintenance of the air handling system, your air handling system is what you are trying to assess with the air particle counter or your air surveillance sample. Then biological monitoring of sterilization processes. This can include even your CSST biological indicator, which is also, the biological indicator is also part of the surveillance screening. So that would also come under routine environmental or routine microbiological sampling. So in general aspects, we have to define the purpose. Why are we doing it? We should have that idea very clear. And second is we have to identify the methodology that we are using and the use of controls. Now coming to water surveillance, because this is one situation where we have agreed without any controversy that we need periodic surveillance in a healthcare facility. Healthcare facilities that conduct water sampling should have their samples assayed in a laboratory that uses established methods and quality assurance protocols. Now, like I said before, most of the hospitals, even if their lab is NABL accredited, the scope would be medical testing. You can check your certificate also. So, for the water sampling and the report to make sense, it should have their samples assayed in a laboratory that uses established methods and quality assurance protocols for water testing. Now, water specimens are not static specimens at ambient temperature. Potential changes in both numbers and types of microbial populations can occur during transport. So, whenever we transport patient samples, I'm drawing examples from patient samples, not that patient samples as part of surveillance. So, when we collect urine sample, we know that it has to be transported immediately to the microbiological laboratory. If there is a delay in the transportation, we keep the urine sample in a lower temperature, at a lower temperature like a fridge. Now the thing is, most people don't realize that when you do water culture and you're collecting water sample, that also needs to be treated like that, because we are trying to see if there is bacteria in the water sample. Suppose there actually is some bacteria. Now if you keep it at room temperature for 2 days before sending it to the lab, the 5 bacteria which was initially present is going to get converted into 500 bacteria within that 2 days. So, in your microbiological analysis of the water, if you have seen the report, it shows CFU caramel.
And what is the duration to take water surveillance in a healthcare, ma'am?
Can we please finish the topic and keep the questions for the end? Is that okay? Otherwise, I'll lose the flow of narration. Is that okay?
Okay, ma'am.
So, where were we? Yeah, so water specimens are not static specimens. So it's not that we have this thought that it is just water. We can keep it at room temperature and we can send it as per our convenience. Even if the day of sending, the day that we are required to send sample is a Thursday, we may be tempted to collect it earlier ahead on Tuesday or Wednesday and keep. But please don't do that, because what differentiates a normal water sample from an abnormal water sample is the cutoff. So initially the water sample may have contained only 5 bacteria, which is within normal limits. But if you keep it at room temperature, the bacteria may multiply. They are not static. They are very much active. They may multiply and get converted into 500, which is above the cutoff. So water specimens are not static specimens at ambient temperature. So you have to keep it refrigerated, just like how you would refrigerate a clinical sample. Potential changes in both numbers and type of microbial populations can also occur during even transport. So it is important that you transport it within a defined time frame, or if there is longer duration, maintain the cold chain or use chemicals which. Can I request you all to please mute? So there should not be any change in the microbial population during transport. Consequently, water samples should be sent to the testing laboratory cold. Okay, and that is approximately 4 degrees Celsius. And testing should be done as soon as practically possible after collection, preferably within 24 hours. If there is a delay, keep it at lower temperature and then transport. Microorganisms in finished or treated water often are physically damaged or stressed. So, if it is a chlorinated water and chlorination is not uh, done completely so as to kill the bacteria, but it has been suboptimally achieved that the bacteria has kind of frozen to the point that growth is limited when assayed under standard condition. Such situations lead to false negative readings and misleading assessments of water quality. So it is good practice to not immediately take water for sampling immediately after a chemical treatment, because that can give you a false negative result. What you want is a negative result, but you want a true negative. You do not want a misguided negative. So immediately after chemical treatment, do not collect samples. Give it some settling time and then collect. Make sure that the water has moved through the entire pipeline or your water supply system before you take a sample. Because most water sampling in healthcare facility involves the testing of finished water from the facility's distribution system, reducing agents such as sodium thiosulfate needs to be added to neutralize residual chlorine or other halogen in the collected sample. See, water sampling, we have said that it requires to be done periodically, but once we accept that it has to be done periodically, we think it is easy. Take a sterile container, collect water and give. But there are so many points which can affect the result and give us false positives or false negatives. That is why these points are being discussed in detail here. So when you collect the sample again may have had 5 bacteria, but chlorine also is being collected along with it. Now the thing with chlorine is it will, as long as it's not immediately at the point of introducing chlorine that it produces disinfection, it will continue to act for a long period. So even after the water has been collected, the chlorine will be continuing to act, but bacteria is also present, which may get masked when we do culture at that point. So whenever you are taking treated water for culture, use a neutralizing agent, or as we call it here, reducing agent like sodium thiosulfate, to neutralize residual chlorine, so that if at all bacteria is present in that sample, we can bring it out during culture. If the water contains elevated levels of heavy metals, add a chelating agent to the specimen, because it is not just about microbiological analysis, you will be doing a physicochemical analysis as well. The minimum volume of water to be collected should be sufficient to complete any and all assays indicated. 100 ml is considered a suitable minimum volume. Sterile collection equipment should always be used. So your average urine sample container would have a volume ranging between 30 ml and 50 ml. So you can't send water sample in that uricol bottle and think that, I've sent it in sterile bottle, I've given them as much as we send urine, that should be enough for culture. The way we do clinical specimen culture is different from how we do water culture. So for water culture, whatever be the technique that is used, the minimum volume that needs to be sent is 100 ml. It is good if you have sterilized bottles of suitable volume for the purpose. It is good if you can send 500 ml. You can use a borosilicate bottle with a cap also. You can sterilize the bottle and reuse it also. But it is good if you send, it is absolutely required that you should send at least 100 ml. It is good if you can send up to 500 ml. Sampling from a tap requires flushing of the water line before sample collection, because the minute we close the tap, there is going to be water in that pipeline right up to that water tap end. Right up to that end, water will be remaining stagnant. So the next time when you open it and you're collecting it for culture, the stagnant water is going to be collected. It will give you false positives. Just like how we don't want false negatives, we don't want false positives also. We want a proper result which is indicative of what is happening. So when you use a closed water for collecting sample, flush out the initial water and then collect the water sample. If the tap is a mixing faucet, attachments must be removed and hot and then cold water must be run through the tap before collecting the sample. That is, if it is a tap that has, if you have hot and cold waters being dispensed from the same tap, that means both of these waters are coming from different parts of the storage system. So you should flush out both the hot water and the cold water through the faucet before you collect the sample. If the cleanliness of the tap is questionable, disinfection with 500 to 600 sodium hypochlorite and flushing the tap should precede sample collection. Suppose if the tap is not proper or it is not neat, it is not well maintained, it is little dirty, the sample that comes through the tap will also contain microbial burden. But does that mean the water is dirty? No, the tap was dirty. That should not yield a false positive result. So if you have doubt that the tap is dirty, clean the tap first, so that the tap does not, mislead us. Just because the water is coming through it, the water does not get dirty. Now, after the tap is cleaned and you collect water, if at that point you get a growth in your culture, then you know that it is not because of the tap. It is because the water itself is of poor quality. Otherwise, you will keep things. The minute you get growth in your water, you think, it must be because of the tap. You will be again in a neither here nor there situation. So avoid all these confusions. If you think the water tap looks dirty, clean it first. Clean it properly using your sodium hypochlorite. Flush out the water. Clean the sodium hypochlorite also from the tap, and then collect the sample, so that if there is growth, you will be clear that it is because of the water itself, not from the tap. So these many points, if you look at it, these many points, these 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 points need to be kept in mind just for collecting water for surveillance. If all these points are not well understood and well, demonstrated during water culture sampling, then your culture result itself can get confounding, or it can yield mixed results which won't help us in any way. Now we come to water sample. The sample water surveillance. The sample should be collected in sterile container. It should contain at least 100 ml volume. It is good if you can send 500 ml. Transportation and performance of culture should be within 24 hours, and even within the 24 hours, it should ideally be maintained at 4 degrees Celsius. 2 to 8 is the temperature of fridge, so if we can keep it in fridge, that is good enough. If it is chlorinated water, make sure that you use a neutralizing agent or a reducing agent like sodium thiosulfate at the time of sample collection itself. Now, what are the sampling sites? This is the most important $1 million question. Where all do you collect samples from? Now, NABH standards very clearly say that whatever be the water source of the hospital, the source itself should be tested. If it is well water, from the well itself, the water should be tested. It's not that the water from the well should be pumped into the tank. From the tank, it comes into the tap, and from the tap, you test the water. No. You collect the water from the tank, from the well itself, and you test it. That is testing the source. Now, NABH standards also say that hospitals or healthcare facilities should always have an identified alternate source. Because, like I said, everything in the hospital will require water to be used. It is important that even if there is a shortage of supply from your primary source, whatever be the secondary source that you have identified, that should also be tested and kept ready so that there is no delay at the time of emergency. So, your water source and your alternate water source should be tested as per NABH standards. This should be done at least once in 6 months from a NABL accredited laboratory or a laboratory that uses demonstrable quality assurance methodologies, and it uses demonstrable standards for reporting also. Then there should be sampling of the potable water. Whatever water is being used or supplied in the hospital for drinking purposes, that is potable water, that should also be tested. The endoscopy rinse, whatever sample or water is used for rinsing out your scopes in bronchoscopy or in endoscopy, that should be tested. Your dialysis unit, that we have said earlier itself, dialysis unit, you have to sample your water at least, not at least, you have to do the sampling once a month. That is an absolute requirement. So what is done in most of the institution is, so there will be one source, and from that source, the RO water will be supplied to different RO water pots corresponding to the dialysis beds. So the source, the RO water source, the tank is going to be fixed. Now, from the tank itself, if you test for every month, that is sufficient. But what is done usually is, if there are 20 RO water pots in a hospital, first month from 3 RO water pots, RO water pot 1, 2, 3. Then second month 4, 5, 6, 7, 8, 9. So basically you're testing the same RO water, but you're testing it from different pots so that you can be sure that the pot is also not contaminated. One shot, two birds dead. So dental unit chair water, this is something that most people miss. But this again is a water that is used for rinsing mouth during dental procedures. So there will be a lot of abrasions in the mouth, and if at all it is contaminated water, it is going to directly enter the bloodstream. And your alternative source, these many should be tested at least once in 6 months. Where dialysis unit is concerned, it should be tested every month. So I hope that is clear. I think this is what someone had unmuted and asked me. That is why I said we keep the questions for them, because most of the routine questions are covered in the session itself. Now, culture methods in interpretation. There are a lot of culture methodologies. Now, all these methodologies, your microbiologists will already be familiar with. They would already be employing it also. It is not for. It is sufficient that microbiology team is aware about this and they are doing it. Just for completion's sake, I am mentioning it so that you know it is not just one method. There can be different methods used. There can be tube methods where you take, like we had said, there will be 100 ml water that is being collected minimum. So this water will be introduced in different volumes into tubes which contain the broth or the growing media. Liquid media will be there in the tubes, and into that the water will be inoculated and incubated. So that is multiple tube method. This will help in titrating up to what concentration microbes are present in the water. Second is membrane filtration. Just like how you use a sieve for filtering your tea, the membrane filter has very nano pores. So through that water will be flushed and the membrane itself will be taken and cultured. So whatever water has passed through, if at all any microbe is present in that water, the entire microbes will be sitting on that filter and the filter itself will be cultured. Then there is pore plate. Same like multiple tube method, in different concentration it is poured into culture media and the culture media is then made into plates. That's all. Spread plate, where you culture it on the surface. Presence or absence method. So the first four methods give you a quantitative, what is the volume of microbial burden. Presence absence method just tells you whether bacteria is present or not. So there are different culture methods and the interpretation of each of these has different standards also. That is why we insist that at least once in 6 months you send it to a laboratory which is accredited for that purpose, or it has quality control measures suitable for this purpose and uses appropriate standards for interpretation. Then there is endotoxin detection methods. Again, this comes into a higher or more important profile in dialysis units. Gel clot technique, turbidimetric technique, chromogenic technique. These are different techniques which are used. The most easiest method would be turbidimetric or gel clot technique. Some hospitals perform it in-house, but most of the hospitals outsource it because the kit comes costly, and if you do not have sufficient number of samples per month, it can get expired and lead to loss of financial repercussions would be there. So you can outsource it also, but make sure that it is done on a periodic basis for dialysis as much as possible, along with the culture endotoxin detection method also should be done. Then there is physicochemical analysis. Along with microbiological analysis, it is good to have physicochemical analysis done. So again, this will come as once in 6 months at least. pH, turbidity, color, order, taste, etc. All of these will also be charted and included in the water physico-biochemical analysis report. So, if bacterial counts in water are expected, now we have said as points what need to be considered during collection. We have covered points on how to collect, what and when to collect. We have covered. Now we come to the point of what needs to be kept in mind while we are interpreting it. If bacterial counts in water are expected to be high in number, example during waterborne outbreak investigations, assaying small quantities using pore plates or spread plates is appropriate. Among all the 5 methodology that was said, during outbreak it is good to use pore plates. Membrane filtration is used when low count specimens are expected and larger sampling volumes are required. So if it is 100 ml or more which is being sampled, it is difficult to culture very high volumes of water samples. So if you use a membrane filter, the entire 100 ml can be pushed through the filter, and if at all any microbe is present in the 100 ml, all the microbes will be present on that filter. So it is easier to culture and quantity. So when it is low count specimens, this is, or when it is high volume sample, this is the better method. The sample is filtered through the membrane and the filter is applied directly face up onto the surface of the agar plate and incubated. Assay methods specific for clinically significant waterborne pathogens are more complicated. See, in our routine methodology, we can detect Escherichia coli, which is an indicator of fecal contamination. That is what we are looking for in most situations. We can catch Pseudomonas non-coliforms also. We can catch or we can diagnose in our routine surveillance water culture. But when you're looking for specific fastidious atypical organisms like Legionella, Aeromonas, Acinetobacter, they are a little more complicated and they will require specific media. You cannot use your routine water culture media and expect to isolate this. If you have these in your mind and it is being done specifically as a targeted surveillance, you have to use specific media and it might be a little more of a costly affair. So they are more complicated and costly compared with both methods used to detect coliforms and other standard indicators of water quality. So we have finished water surveillance. This is what is being done on or what requires to be done on a routine basis. The periodicity, the sample collection, the methodology, the interpretation, everything we have covered. Now we come to air surveillance. So in air surveillance, routine air sampling, random and undirected, is not recommended because hospital-acquired infection rates are not related with levels of general microbial contamination of air. Do not do air sampling as a routine and random thing. Do it as a targeted methodology. Do it for specific sites and be very sure about what you're looking for. Randomly and aimlessly do not do sampling. So, what are the sampling methods for air surveillance? You can have settle plate method, which is the most routinely used, most financially feasible, economically viable methodology. You do not require any additional equipment for this. You just need a culture plate. Then you have sieve impactor, slit to agar impactor, centrifugal sample impactor, gelatin membrane filtration, and air particle counter. So the last 5 require or actively push or pull air through the equipment, which helps in sample collection. Whereas in settle plate method, it occurs by itself. Now what we need to understand is clean room versus others. So what I have sadly observed in many institutions is air sampling is done for multiple places within the hospital, and all of these air samples are interpreted on equal weightage or equal leverage is being given to all. How can you expect that the standards which are used to interpret the air surveillance of an OT can be applied in a ward also? You cannot interpret the same or you cannot use the same yardstick for measuring both. When you're doing surveillance of your sterile rooms, what you're looking for, what you're willing to accept is completely different from what you're willing to accept or what you're keeping as a cutoff for other areas. There is no reasonable requirement for other areas to be sampled. But if it's a recently constructed or innovated area, you may have to do a air sample surveillance. In that case, please do not do the surveillance using the same yardstick as what you do for your OT. Clean room is a completely different level, and the other parts of the hospital are a completely different level. So please do not use the same yardstick. All this interpretation will be done by the microbiology department and it will be mentioned and given to you in a report. But as infection control professionals at various levels, we all need to understand that microbiology team has a different cutoff. They'll interpret and give it to us. We can't start asking them, last time there was 9 CFU and you said I have to close the OT. This time there is 9 CFU and you're saying I can open the area. So it is because the cutoffs are different. Clean room is a completely different category versus all the others in a different category. Now, non-microbiological parameters are also included, which can have an impact on the outcomes. Air changes per hour. So, the number of air changes per hour in an OT, the number of acceptable air changes per hour in an OT is different from a bone marrow transplant unit. It is different in a labor unit. So, it is different in an ICU. It is different in an isolation unit. So the air changes per hour can also have a bearing. The air velocity, positive pressure environment in comparison to negative pressure environment, temperature, relative humidity, the layout of your air handling unit, wall and ceiling composition, number of persons present. All of these can have a bearing on your interpretation. In an operation room, if you are doing air surveillance before the OT starts working, your expectations, your results will be one. And in the same OT, if you collect sample during performance of an operation, your interpretation and your findings will be different. Does that mean that the OT has become contaminated when people have entered? No, it just means that what is normal in an empty room versus what is normal during a case or a procedure are completely different. You cannot use the same yardstick. It will depend on the relative humidity. It is not just about sterilization. Your wall and ceiling composition, whether they are able to retain moisture, whether they are able to fester microorganisms. With increase in relative humidity, there will be increase in the viability of the microorganisms present in air. With increase in relative humidity, your HEPA efficiency will decrease. So there are a lot of factors which come into play. You cannot just play a loose ball with air surveillance reports. Air sampling for quality control is problematic because of lack of uniform air quality standards. For example, although airborne spores of Aspergillus species can pose a risk for neutropenic patients, the critical number of these spores above which outbreaks of aspergillosis would be expected to occur has not been defined. So, in where do you see neutropenic patients? In your oncology unit or in your BMT unit. So, in how you interpret air surveillance in that unit would be different from how you would interpret in say your operation room. Because in operation room, aspergillus spores are not that much of a problem. It will be cleared by your HEPA and that is sufficient. But where neutropenic patients are concerned, even transient plus presence of aspergillus spores can have an impact. So the action level would again vary. You cannot have one yardstick for all. That is the problem that is the point that I want to convey. So healthcare professionals, considering the use of air sampling, if you're doing air sampling, you should keep in mind a few things. You should keep in mind that the results represent indoor air quality at singular points in time. At that specific point of time, what is happening, that is all you can say. If you do sampling of OT1 at 7:30 a.m. before the first case, then it shows and it has passed the result test. It just means that at 7:30 a.m. OT1 was fine. It doesn't show that, doesn't mean that OT1 is fine for the next 1 week. You cannot interpret like that. So it represents indoor air quality at singular points in time, and these may be affected by a variety of factors, including the same points that I said earlier. Indoor traffic, that is how many people are present, visitors entering the facility, temperature, relative humidity, time of the day or year, relative humidity, relative concentration of particles or organisms, and the performance of air handling system components. All of these have a bearing. Now, when it is the point G, as in it is the when it is the when there is an abnormality because of the performance of air handling systems, that is when we are actually concerned and worried, because if it is performing suboptimally, the air quality is never going to be good. That is when we have to take an action. So the use of settle plates, example the sedimentation, that is the sedimentation or deposition method, is not recommended when sampling air for fungal spores, because fungal spores have this particular nature that it won't settle fast. They are actually very lightweight and they get easily distributed. It's just like pollen grains. Pollen grains, you must be remembering Brownian movement that we studied in physics in school. They remain suspended in air. You can keep an agar plate down, but it will remain in air and it won't come in the settle plate. So you will get a false negative report saying that there is no fungal spores. So the use of settle plates is not recommended when you're specifically looking for fungal spores, because single spores can remain suspended in air indefinitely. In such situations, you have to use a sieve impactor or a slit impactor, one of those things where air is sucked in. If you are looking specifically for fungal spores, if you're looking for a unit where there is neutropenic patients and you're looking specifically for fungal spores, then use sieve impactor or slit impactor, one such methodology where air is sucked in or pushed in. Settle plates can be used for all other situations. Where you are not specifically looking for fungal spores, you can use settle plate method. It is very economically viable. Settle plates have been used mainly to sample for particulates and bacteria, either in research studies or during epidemiological investigations. Now we come to surface surveillance. We have finished water and air. In 10 minutes, we'll be able to finish surface surveillance, because surface surveillance, the most important point is don't do it. Don't do it routinely. Do it only when it is indicated. And when is it indicated? When there is an outbreak, when you are doing it as part of research, when you are assessing whether your change in infection control practice is sufficient, or when there has been a change in the environment. These are the only situations where you have to do a surface sampling. Otherwise, please do not walk around with a swab stick of 10, 20 and send it every day to your microbiology lab. Surface sampling is used currently for research as part of an epidemiological investigation. If there is an MRSA outbreak, you're looking for MRSA. That is when you do a surface sampling. Or as part of a comprehensive approach for specific quality assurance purposes. As a research tool, surface sampling has been used to determine potential environmental reservoirs of pathogens, survival of microorganisms on surfaces, and sources of environmental contamination. Again, in this also, it is not just a question of when to do and how to do. There are certain points that we need to keep in mind so as to avoid false positivity and false negativity. Because at the end of the day, with surveillance samples, we are looking for, or with surveillance reports, we are looking for answers to our questions. So, if disinfectant residuals are expected on surfaces being sampled, specific neutralizer chemicals should be used in both the growth media and dilution or rinse fluids. Lists of the neutralizers, the target disinfectant active ingredients, and the use concentrations have been published. Alternatively, instead of adding neutralizing chemicals to existing culture media, the use of either a commercially available media, including variety of specific and non-specific neutralizers, can be used, or double strength broth media, which will dilute the inhibitors and help in the recovery of microorganisms. Very simply, I'll put this entire entire point into one simple sentence. If you are using a new disinfectant and you want to see if it is working, like how we said earlier about chlorinated water, the chlorine will continue to act even after sampling. Similarly, the disinfectant, if it is still present on the surface at the time of sampling, it will continue to act and it will give us a false positive. So what we need is, here also there should be neutralizing agents. The list of neutralizing agents are usually available as there are common neutralizing agents which can act on most of the disinfectants that can be referred, or you can use double concentration. So these disinfectants will get diluted and the microorganisms can be recovered. If sampling is conducted as part of an epidemiological investigation of a disease outbreak, identification of isolates to species level is mandatory and characterization beyond the species level is preferred. For example, if there is a MRSA outbreak and you are looking specifically for MRSA, you have isolated MRSA from 3 patients. The first step is we have to see if all these 3 MRSA are the same one. If the 3 MRSA are completely different, one has MEC-A gene, one has MEC-B gene, one has MEC-A and MEC-B gene, then are we talking actually about an outbreak? It happened that they are all MRSA, but they are not genetically similar. Then it is not the same bacteria or the same strain which is causing problem. So at the patient level itself, we have to see if it is the same organism. Forget that, keep that in mind. Now, when we do surveillance sampling, in surveillance sampling, it is absolutely mandatory. You can't give a loose comment like Staphylococcus species isolated. That kind of sample report cannot be used in surveillance sampling. For patient sample, to a point, you can give Staphylococcus species, because at the end of the day, if you get a sensitivity report, the patient will be treated. But surveillance is done to identify the source. So you cannot give Staphylococcus species or Klebsiella species and close it up. It has to be done mandatorily to the species level. Whether or not it is aureus has to be mentioned. And preferably characterization beyond the species level, that is the genetic makeup, is also preferred. When interpreting the results of the sampling, the expected degree of microbial contamination associated with the various categories of surfaces should also be considered. Now, surface surveillance, how can surface surveillance be done? It is mostly using swabs, moistened swab. Then you can do a wipe sample. If it is a huge surface, if it is suppose a table, then you can't walk around with a swab and rub the whole table, right? In that situation, you can do a wipe sampling using a sterile cloth, but you wipe it. Spatula sampling, direct contact plate. If it is, say, a cloth or something, you can take the cloth and apply it on that. That is direct contact plate. And then you can do immersion method. If it is a liquid, you can immerse. There are culture media which can be done by immersion method also. Now, interpretation up to species level is mandatory, and in case of an outbreak, molecular method of genotyping is also recommended. So that brings us to the end of the session. I will be happy to take any and all questions that you have. We have 8 minutes. So, where to take air samples? So, I think the question must have been asked before I explain. I explained very clearly where to take air sample from. You have to take it from your sterile units. If you have positive pressure areas, you can take samples from there. If you have your BMT isolation units, burns unit, etc., you can take. Other than that, routinely do not go about taking samples from your common high flow areas. Kindly guide routine surveillance of OT and ICU. I have already elaborated that. Is water surveillance required for scrub station of OT and other areas and pantry? It is a good practice. It is definitely a good practice, but it is not mandated. If you have an outbreak in your OT or an outbreak of SSI, you have to do it. You have to do scrub station of OT. Otherwise, testing of the general source is sufficient. How many time air culture should be done per year? This can be defined in the institution. The institution itself can define. It is usually the internal policy that is used as a reference during even accreditation or audit inspections. But once in 3 months is a good way to go. That is a good frequency to stick to. Should we do air sampling after change of HEPA filter? See, there is something called change of HEPA filter, yes, but there is something called validation of HEPA filter. So whenever there is installation of HEPA filter, immediately after that there will be validation. Validation is a mechanical process by which the installers or their mechanical engineers will be checking or validating whether the HEPA filter is working adequately. So that mechanical evidence is already there. You do not have to immediately afterwards do a air sampling. Whereas the HEPA validation will be done once in 6 months. Somewhere with not directly overlapping with the HEPA validation, you can set your air sampling frequency so that somewhere midway between the HEPA validation, you do a air sampling. That way, you will get a 360-degree evaluation of your air handling system's efficacy. Are there any other questions? If you have any other questions, you can unmute and ask, or you can post as a message also. Both are fine. So there is a outbreak, there is increased number of SSI, specific methods to reduce SSI. So we call it as an outbreak of SSI. There are 2 different types of outbreaks. One is when there is a specific organism which is causing SSI again and again. In that situation, our aim would be to find the source of the organism. The second type of outbreak is when the organisms are different, but there is an increase in the number of SSL. So in that case, we are not looking for a specific organism. In most likelihood, it is a practice which is leading to a problem. So both of these, whatever it is that you are facing, we have to look at it divergently and approach the problem, find out the solution. If it is one organism, then your surveillance would be targeting the organism. You are culturing everything to see if it is MRSA outbreak, you are culturing it to see if MRSA is present or not. If it is different organisms, then it is a more challenging situation where you have to observe the practices and see what is common between the organisms. For example, if for one patient it was MRSA, one patient it is Staph aureus, one patient it is Klebsiella, one person it is E. coli. What is common between these organisms, and what are the sources from which these different organisms can enter the surgical site? So depending on how it is, we have to approach the problem, and we have to find out. We have to come to, like we said in the earlier session, we have to develop hypothesis. Once we have 5 or 6 hypotheses, we have to look to see which is the most probable one, and to determine or to conclude which hypothesis is in fact true, we need evidence also. Once we get the evidence, confirm the hypothesis and take corrective action. If that's all, we can move. It's weekend, Saturday. Weekend wishes to you all. I hope the session has been worth taking 1 hour out of your weekend. So that is the last session that I have for the crash course this year.
Madam,
Yeah.
Madam, one doubt, madam. When we take samples during outbreak, water samples, for example, newborn and or Klebsiella outbreak.
For what outbreak?
Klebsiella outbreak in the newborn.
In the newborn ICU, in a specific
ICU.
So when you are working in an ICU, the good thing is there is no cross movement of equipment. Most of the ICUs would have a defined set of equipment. There may be fixed ultrasonograms, ECG would be fixed. All this equipment would be fixed. Now, when you're dealing with the organism like Klebsiella, the most difficult thing is Klebsiella can survive almost anywhere and everywhere it can survive. For example, there may be stethoscopes which are used for examining the babies. You can start with the stethoscope. If the stethoscope is moving from baby to baby, that can be a source. If stethoscopes are hung next to each bed, still it can be a source, because between patients, whether it was sterilized or disinfected, we do not know. The cot warmers itself, the syringe pumps, the water source, the feed preparation area, and then after you look at all the environmental aspects, you have to come finally to the most difficult part, which is surveillance of healthcare providers. You may have to screen your doctors and your nurses, your housekeeping staff, but keep that for them, because it is a very difficult task. Look at the entire environment, and when you're taking sample from the warmer, please understand that the warmer does not include just the rails. For when you're taking a patient cot sample, you take the handrails. See, babies are, their movement is restricted to the inside part of the cot. So wherever the baby's body is touching, that you can take. If it is a baby which has multiple lines, you can take samples from the lines also.
Okay.
And whatever equipment has been routinely used for enlist the number of babies for whom Klebsiella has been identified, and what has been used commonly for all of them. Or if it is, at the end of the day, if it is a common person or a common equipment, that has to be included definitely in your surveillance.
Okay, madam.
Not easy, but it will take some time, but you can do it.
But once our quality of water supply is very bad actually in our government.
You have
whenever we test the water samples, we get all these E. coli, Klebsiella, and
what you do is, see, if you are getting Klebsiella from your NICU, that is from your NICU, if you are getting Klebsiella, request your microbiology lab to preserve that strain. Then next time when you do a water culture, You ask microbiology laboratory, that is called targeted surveillance. You ask them, I want to see how much Klebsiella is present in it. Because routinely in our water surveillance, we do E. coli, we do count of E. coli. We do not pay that much attention to Klebsiella because we are looking for fecal contamination and water quality. So you ask them, I want to know how much of the Klebsiella is present in it. Ask them to isolate it. Then compare these two. See if both are same. There is a probability that it could be the same. The same could be the source. But there also exists a probability. 90% I'm telling you, both will be Klebsiella, both will be different types of Klebsiella because water source leading to outbreak will not be restricted to NICU alone. It will lead to an outbreak in multiple parts of the hospital. So both will be Klebsiella but different types. So as long as you have it in your mind that my water source is bad, that could be it, your eyes won't open to the probability of something else being the source. So rule that out and then move ahead.
Okay. Thanks.
Yeah. So if you have any queries,
Yeah, ma'am. Ma'am, one question. So, how should we take the samples from hand? Like recently, we have an outbreak of Klebsiella in your ICU in our hospital. So, our microbiologist has suggested hand swabs of the healthcare workers, those who are working in your ICU. So, did the hand should be washed before taking the culture? Because all the culture what we took came no growth.
if all the cultures came no growth, first you have to inspect your culture media because no matter how well you wash
The
your
corns, we have suspected some corns. That was not came.
Okay. For surveillance to make sense, what you should do is you should wash your hands. You should ask the healthcare providers to wash their hands before you do the surveillance sampling. Because
We done that.
you did after washing the hand?
Yeah, ma'am. I told them to wash their hands and first 3 fingers on the media and from both hands and then swabbing using saline and then stretched on the plate. That plane came no growth.
Okay, so the best way to do surveillance of healthcare workers, especially hand, is to get bigger culture media, bigger Petri plates. The routine Petri plates are 90 mm. So you get 150 mm Petri plates. So most of the people's hands, an average human being's hand will fit easily into the Petri plate. You ask them to do impression on the plate and then you incubate it. That will give you an idea of what is on the high touch surfaces of your hand. That is what you want.
The 3 fingers we can able to that smaller media. Only the tip part.
Yes. No. It's not tip. It's not just tip. See, there are very few things that we do using the tip alone. Most of the activities that we perform in an ICU or in patient care, we use our whole hand. So that is why I said the hand itself should be impressed on the plate.
Okay, ma'am. So before that sampling, the hand should be washed.
Yes.
That was my point.
Yes.
Yeah. Okay, ma'am.
Because whenever you are touching a patient, you have to wash your hands before. So that is what we want to know. Before touching a patient, after taking precautions, how much of bacteria is present in the healthcare provider's hand.
Okay, ma'am. Okay, ma'am. Thank you.
If there are any other queries, I will post a message in the group. My number will be there. You can contact me at any point of time. I may not be available for answering calls, but you can always leave a message. So, eventually, I will get back to the question and I'll respond to your questions. So, thank you so much. All the best for your exams. Hope all these Saturday evening sessions have been worth it. Thank you so much. Yeah. Bobisha, I'm off.
Yes, ma'am. Thank you, ma'am.
Bye. Good night.
Good night.
Thank you, Bobisha.
Thank you, ma'am. Bye.
बंद हो गई क्या? ये तो बंद क्यों हो गया? क्या था? बड़ी जल्दी बंद हो गई। एक मिनट, चल बंद हो गया तो अच्छा है, फिर मैं ले चलती हूँ। चलो।